Hello and welcome to Easy Learning with Dr. Salman Khan. Next is the clinical features. First, amoebic dysentery. The symptoms occurs when the parasite invades the intestinal wall and ulcers develops. The symptoms are moderate to profuse diarrhea containing blood and mucus and severe abdominal pain. Next, chronic amoebic dysentery, or also called as amoebic colitis. The symptoms are intermittent diarrhea over a long period of time, and it can often be misdiagnosed as ulcerative colitis or irritable bowel syndrome or IBS. Next is the differences between amoebic dysentery and bacillary dysentery. Clinical features: the onset in amoebic dysentery is gradual, whereas in bacillary dysentery it is acute. In amoebic dysentery, fever and vomiting is absent, whereas in bacillary dysentery, there is fever and usually vomiting also is present. Toxicity is absent in amoebic dysentery, whereas it is present in bacillary dysentery. Abdominal tenderness is localized in amoebic dysentery, whereas it is generalized in case of bacillary dysentery. And tenesmus is absent in case of amoebic dysentery, present in case of bacillary dysentery. Then regarding the feces, amoebic dysentery presents with 6 to 8 motions per day, whereas in case of bacillary dysentery, we see more than 10 motions per day. The amount is relatively copious in case of amoebic dysentery, whereas it is small in case of bacillary dysentery. The odor of feces is offensive in amoebic dysentery, and the feces is odorless in bacillary dysentery. The color of the feces is dark red in amoebic dysentery due to altered blood, and bright red in bacillary dysentery due to fresh blood. The nature of feces: blood and mucus is mixed with feces in amoebic dysentery, whereas in bacillary dysentery there is blood and mucus with little or no feces. And reaction: the stool is acidic in case of amoebic dysentery, whereas it is alkaline in case of bacillary dysentery. Consistency: in amoebic dysentery, the fluid mucus is not adherent to the container, whereas in bacillary dysentery, the viscid mucus is adherent to the bottom of the container. Next, the microscopic appearance of feces. We see the presence of RBCs in amoebic dysentery, which are in clumps and reddish yellow in color, whereas in bacillary dysentery they are in discrete or in Rolex formation with bright red color. Pus cells are scanty in amoebic dysentery, whereas they are numerous in bacillary dysentery. Macrophages very few in amoebic dysentery, whereas large and numerous with containing RBCs in case of bacillary dysentery. Eosinophils are present in amoebic dysentery and scarce in bacillary dysentery. Ghost cells are nil in amoebic dysentery and numerous in bacillary dysentery. Trophozoite: the trophozoite of ENTAMOEBA histolytica is present in amoebic dysentery, whereas it is absent in bacillary dysentery. There is presence of Charcot-Leyden crystals in amoebic dysentery, absence in bacillary dysentery, and the motile bacteria are present in amoebic dysentery and absent in bacillary dysentery. The clinical features of amoebic liver abscess: fever is present in most cases. Anorexia, nausea, weight loss and fatigue may also be present. Pain in right hypochondrium is present due to stretching of liver capsule. Then the signs are jaundice and diminished respiration on the right side due to hepatomegaly. Next, pulmonary amoebiasis. Clinical features: the symptoms: the patient presents with severe pleuritic chest pain, dyspnea and non-productive cough. Next, the metastatic amoebiasis. Abscesses in kidney, brain, spleen and adrenals have been noticed. Spread to brain leads to severe destruction of brain tissue and is fatal. Next, the cutaneous amoebiasis. Extensive gangrenous destruction of the skin occurs. The lesion may be mistaken for condyloma or epithelioma. Next is the laboratory diagnosis. The diagnosis is divided into: first, diagnosis of intestinal amoebiasis; second, diagnosis of extraintestinal amoebiasis. First, intestinal amoebiasis. It is diagnosed through stool examination, stool culture, mucosal scrapings, serodiagnosis and molecular diagnosis. First, stool examination. Stool examination is done macroscopically as well as microscopically. Microscopic study is done in a saline preparation. Macroscopic appearance: the stools are foul smelling, copious, semi-liquid in consistency, brownish black in color, cellular and intermingled with blood and mucus, and they do not adhere to the container. Microscopic study, the findings are the cellular exudate is scanty and consists of only the nuclear masses, that is pycnotic bodies of a few pus cells, epithelial cells and macrophages. The RBCs are in clumps and yellow or brown red in color. Charcote Leyden crystals are often present. These are diamond-shaped, clear and refractile crystals. Actively motile trophozoites throwing pseudopodia can be demonstrated in freshly passed stool. Presence of ingested RBCs clinches the identity of Entamoeba histolytica. Nucleus is not visible, but a faint outline may be detected. Cyst has a smooth and thin cell wall and contains round refractile chromatoid bars. Glycogen mass is not visible. These are the Charcote Leyden crystals when viewed under a microscope. Next, the stool culture. Stool culture is a more sensitive method in diagnosing chronic and asymptomatic intestinal amoebiasis. Culture of stools yields higher positivity for Entamoeba histolytica as compared to direct examination. Stool culture is of two types. First, polygenic culture. It is done in an enriched medium which contains bacteria, protozoa, serum, starch, etc. for nourishment of the amoeba. And second is the axenic culture, which is done in a medium that does not require the presence of other microorganisms. Next, mucosal scrapings. Scraping is obtained by sigmoidoscopy and is often contributory. Examination method includes a direct wet mount and iron hematoxylin and immunofluorescent staining with anti-Entamoeba histolytica antibodies. Next, serodiagnosis. Serological tests become positive only in invasive amoebiasis. The types: first, amoebic antigen detection. Amoebic antigen in serum are detected only in patients with active infections and disappears after clinical cure. Antigen like lipophosphogycan, LPG, amoebic lectin, serine-rich Entamoeba histolytica protein, that is SREHP, are detected using monoclonal antibodies by ELISA. Stool antigen detection. Detection of coproantigen of Entamoeba histolytica in stool by microwell ELISA is more sensitive than stool examination and culture. Next is the antibody detection. Amoebic antibodies appear in serum only in late stages of intestinal amoebiasis. Test for antibodies in serum help in diagnosis of mainly extraintestinal infections. Serological tests include indirect heme agglutination assay (IHA), indirect fluorescent antibody (IFA), enzyme-linked immunosorbent assay commonly called as ELISA, counter-current immunoelectrophoresis (CIAP), and latex agglutination tests called as LAT. Next is the molecular diagnosis. We have deoxyribonucleic acid DNA probes and radioimmunoassay have been used to detect Entamoeba histolytica in stool. It is a rapid and specific method. Then real-time polymerase chain reaction or RT-PCR is a sensitive test for the detection of Entamoeba histolytica from pus of liver abscess. So these are the tests for intestinal amoebiasis. Next, the tests for extraintestinal amoebiasis. These include microscopy, liver biopsy, serological tests, stool examination, and radiological examination. First, microscopy. Microscopic examination of pus aspirated from liver abscess may demonstrate trophozoite of Entamoeba histolytica in less than 20% of cases. In case of liver abscess, when diagnostic aspiration is done, the pus obtained from the center of the abscess may not contain amoeba as they are confined to the periphery. The full draining after a day or two is more likely to contain the trophozoite. Aspirates from the margins of the abscess would also show the trophozoites. Cysts are never seen in extraintestinal lesions. Next, the liver biopsy. Trophozoite of Entamoeba histolytica may be demonstrated in liver biopsy specimen in case of hepatic amoebiasis or amoebic hepatitis. Then serological tests. These tests are of immense value in the diagnosis of hepatic amoebiasis. These tests include complement fixation test (CFT), indirect heme agglutination (IHA), latex agglutination (LA), gel diffusion precipitation (GDP), cellulose acetate membrane precipitation test (CAP), countercurrent immunoelectrophoresis (CIE), and enzyme-linked immunosorbent assay (ELISA). Next, stool examination. It is not of much value as Entamoeba histolytica cyst can be detected in stool in less than 15% of cases of amoebic hepatitis. The radiological examination. On X-ray, the right lobe of the liver is generally found to be situated at a higher level. Radioisotope scan of the liver may locate the space-occupying lesions. Ultrasonography or USG, computed tomography, that is CT scan, or magnetic resonance imaging (MRI) of the liver may be found useful in the detection of amoebic liver abscess. Next, investigations. Blood shows increased WBCs. Stool examination shows the presence of cysts and occasionally trophozoites, and biopsy or aspiration shows presence of trophozoite, and the X-rays show the presence of liver abscess. And lastly, prophylaxis. General prophylaxis is as for all fecal-oral infections. Food and water have to be protected from contamination with human excreta. Detection and treatment of carriers and their exclusion from food handling occupations will help in limiting the spread of infection. Health education and inclusion of healthy personal habits helps in control. So this is all about ENTAMOEBA histolytica. If you wish to see more of such videos, do comment below. And don't forget to like, share and subscribe to my channel. Also, press the bell icon for early notification of my new videos.